Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFL York Operations Coordinator. I would like to officially open the 8th session in our 2025 Emergency Management in Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center. I would like to begin today with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have long-standing relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Takaranto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. The territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our panelists, and our participants from around the world. Welcome to our webinar. It is now my great pleasure to introduce Misha Richard. Misha Richard is the Emergency Preparedness Lead at Thunder Bay Regional Health Science Center and facilitator for the CFL York TBRHSC series and will be moderating today's session. For the sake of time, Misha's full bio and the full bio of all of today's speakers will be shared in the chat. Misha, thank you very much for moderating today's session and your ongoing help in putting this series together. The floor is yours.
Well, hello, everybody, and thank you for joining us yet again. I'm delighted to say that we have a panel today that has representation from 4 different provinces in Canada. So we've got New Brunswick and Nova Scotia out on the East Coast. We have a couple of representatives from Ontario, and we have a representative with us today from Alberta. So as Francesco said, he's going to give everybody's full bios in the chat, but I'll just quickly introduce everyone that we're lucky enough to have with us today. So I'll start off with Laura Kenty. So Laura has worked for 15 years as a frontline nurse in the emergency department before she transitioned into healthcare administration. And she's the current specialist for patient safety and emergency preparedness at Joseph Brant Hospital. Next is Grayson Cockett, who works as a healthcare disaster manager, paramedic, and educator, and a mountain bike coach, very busy fellow. He's also the host for an award-winning podcast, Emergency Preparedness in Canada, or EPIC, and is currently an emergency management officer with Alberta Health Services. Then we have Hajra Khan, who also has 15 years of experience, this case in quality and risk in healthcare. And I want to give a big shout out that I appreciate her joining today as a very last minute addition because unfortunately one of our panelists was not able to attend today. Hajra works at Trillium Health Partners, where she is the Director of Enterprise Risk and Emergency Preparedness, and has successfully led their team in achieving 100% compliance in their emergency preparedness accreditation standards review. So shout out there, that's big props. Then I want to introduce our East Coast panelists. So I'll start with Scott Brimwell. Scott is an accomplished emergency management professional with over a decade of experience in healthcare emergency preparedness at Nova Scotia Health, an additional 10 years of service as a medic with the Canadian Armed Forces Reserves. In his current role, Scott leads emergency preparedness programs for 9 healthcare facilities in Nova Scotia Health's Northern Zone. And last but certainly not least, I will welcome Greg Dunn. He's been involved with emergency preparedness aspects, many aspects over his 35-year career, including his current role as the lead emergency management advisor with Horizon Health in the province of New Brunswick. He's also a surveyor for Accreditation Canada, so he's evaluated emergency preparedness at various health organizations across the country. So thank you all for joining us today. I'll start with a little bit of housekeeping for folks that are new to the series. The chat is open to everybody to have ongoing dialogue. Please feel free to chat in there throughout the session. We learn a lot from each other in that space. But if you have questions that you would like put directly to our panelists, please use the actual Q&A function, and I will moderate that as we go along. So without further ado, I'm just going to start off with what I think is the most basic, is to give a little bit of an overview for folks here on the call. So give me 1 second and I will pull up my slides. And Give me a thumbs up if you can see my speaker. Great, thanks, Scott. So I'm just going to start off by doing this as an overview because for some folks, we know you don't come directly from a healthcare background. So some of you have heard me give a bit of the introduction before, that hospital emergency color codes have existed for decades at this point in time. They were meant to kind of eliminate some confusion by having sort of a general overarching statement to apply for response. And today's topic is going to look at code yellow or missing person. Now, what is it? It's supposed to be a code that's used when we have a missing patient, but it could also be a resident or client depending. We have representatives here from health networks. So my organization is only one critical care facility. We only have one physical space to look at. But for other folks that are on this call, you're dealing with a variety of population between inpatients and residents and so on. And so key actions typically include some sort of search of where that person was either last seen or where they were supposed to be and have not been seen. Some sort of attempt to contact them or their person to contact. Determine if that person is high risk. So some sort of criteria that suggests they really do need to be found right away. Some method to alert our workers. So, we start looking at maybe some public spaces or neighboring departments or communication to security. Potentially it goes to notification to a full facility. We'll get into some of the specifics here. Again, this is our overview. And then something that expands it to a full search of the facility grounds, the campus, so on. And why? Why do we have this? Well, we often end up having to get into notification to external parties for these folks because they've been considered high risk. And what does that mean? Well, this is just the quickest review of some recent headlines. You have individuals who have come to great harm or even death in their communities after leaving their healthcare facility. You have individuals that have caused harm to others. But this is just to show you just that quick snapshot of the number of individuals that have had negative outcomes. And so this is why we're having this talk today, is to say, we have code yellow. What does that mean? What are some of the best practices that we can share and maybe learn some new things through this panel and the questions posed to them? So I'll stop sharing and I'll start with my first question, which is, to everybody here, open question. What are the initial actions that you take when a patient or a resident is suspected to be missing? Who'd like to go first? Yeah, Grayson, jump in.
Sure. So kind of what you mentioned, it's a little bit based on risk and then escalation of search technique. The immediate action, if it's not a high-risk patient, is just to do an overhead page to return to the unit. Hopefully that will resolve it. Of note, we have, in terms of overhead pages, which can sort of be related to code yellow activations at our busiest hospitals, it's about 40 to 50 per month. So this is several times a day. And in most cases, that kind of resolves it, and it's just a miscommunication. If that doesn't resolve it within a certain time period, we put like 15 minutes on it, then you have to do this risk assessment. I'll drop it in the chat here, but basically you're assessing patient characteristics and environmental characteristics to decide if you need to kind of progress slowly through the search or if you need to jump to a major search right away. So that's sort of the initial actions and decision making at a staff level, but the administration behind that is kind of the challenging piece. So distributing the patient characteristics when you do escalate to a larger search is a bit of a challenge. We have a form, we have some distribution techniques based on site, often just email or fax, but getting that information out in a timely fashion is definitely a challenge. I think there's probably opportunities to leverage technology there. And then just coordinating and recording the search is a challenge as well, because the hope is that we'll find them, but if we don't, then we need to prove that we've searched absolutely every nook and cranny before we can sort of transfer over to a different group to continue the search in the community.
Okay, so Grayson, you've jumped like full steam ahead here. If I can rein it back a little bit. So initially you brought up something which is the key piece, like we will try and page to have them return, because not every person who wanders away from their room or their residence is incapable of making those decisions to be able to move about. I know in my own organization, frequently somebody's at the coffee shop in the hospital, and they're allowed to go there. I thought it was interesting to hear you give some stats about, you know, the average of having a couple of these a day. I can commiserate with that. I would say we page a few patients to return to their units daily, and that initial search. But before we get into talking about the actual sort of criteria, that risk assessment, I see Laura and Scott, you both have your hands up. Do you have a process for, you know, what are you doing when you realize somebody is missing? What are those first kind of actions for you? Laura, your hand was up first. I'll go to you.
Sure. Again, we have a staged approach where I work, but that preliminary or stage 1 approach is search the unit or area where the person is assigned, or areas that they're known commonly to be. For example, if the patient is a smoker, they might be out in the smoking section or at Tim Hortons or those kind of things. It does also include an attempt by telephone to contact the patient. Most people have cell phones and most people have those cell phones with them. So that is included in our preliminary search. We rarely overhead announce, mostly because security is notified pretty quickly, and we generally know where they are before we get to that stage. So, but really, if they're outside of the organization, which isn't unusual after hours, if, you know, because our Tim Hortons is only open till 8 o'clock. So if people want a coffee, they're going elsewhere to get it. So, but one thing that we did recently add was that attempt to contact the patient directly. Before that, it was just us looking around.
Okay, and then Scott, how are things done for you folks?
Yes, hi Misha, thank you very much. Hi everybody, happy to be here from Nova Scotia. So I am representing Nova Scotia Health. So just for a little bit of context, so Nova Scotia Health is our provincial health authority. So we have a single health body for the entire province. Population of the province, we recently broke 1 million, so we're coming up there, but we are a provincial health authority, so we have around 45 or so facilities, healthcare facilities around the province, and about 35,000 staff. And we strive to be consistent across the province. So as far as us and Code Yellow goes, within our framework, there are 4 identified phases for a Code Yellow response, and each of them have clearly identified expected actions. And we have checklists to support each phase. So at the stage we're discussing right now, so the situation would be a concern for a potential missing client. So before a Code Yellow was actually declared, we would call that phase 1, the verification of status as missing. And so the actions there include department checks, common area checks, reviewing the schedule of the patient. Maybe they've been taken away for a schedule or a test, the presence of personal belongings, etc. And then we have a checklist for that. So we do refer to it's called the verification of status checklist. I'll just go through that really quickly. Maybe have some benefits of this checklist that we go through. We double check the client room or washroom, check to see if the client's clothing or belongings are missing, check with the client's roommates, check with the staff on the unit, check the lounges on the unit, check the client's appointment schedule. If applicable, call security to assess the cameras, check all the rooms on the unit, including the client room, showers, etc. Have the staff members check the quiet areas, religious area, prayer room, etc. Check the cafeteria, check the coffee room, of course, and then ultimately notify the person in charge of the unit. And then if that person is unavailable, then you would follow your normal procedures and escalate that up. And if that's unsuccessful, that's when we would progress to the next phase, which would be the actual declaring of a Code Yellow.
Great, very detailed. I appreciate that. Greg, do you guys do something different over in New Brunswick? Do you have a bit of a staged approach? I know you're also a network.
Yes, yes, the Horizon Health Network is one of the two health regions in New Brunswick. We have Vitalite as well. We have probably over 100 facilities. I think there's 8 regional hospitals and a number of community hospitals as well. Our challenge is we're an acute care facility, but a third of our hospital beds are taken up by eight altered level of care patients because there's nowhere to go, there's nowhere to place them. So we're really not, so we get patients with early dementia or Alzheimer's who are still within our facility, but like I say, we're acute care facilities, so we're not locked down like some other areas would be. So we have a lot of them who leave. So one of the first things we look at, we do the risk assessment as well, contact the physician, see what the risk is for them. Of course, environmentals, winter, summer, that sort of thing, if they're out the door. But we'll send someone from that floor down to security office to actually look at the tapes, to look at the cameras to see if we can see them leaving. And if we do see them leaving, we'll call off the code yellow because they're now outside of our facility, and we'll bring in our external stakeholders to help us look in for outside. The family is always contacted immediately right after. Usually with these patients, these ALC patients, there's like they're saying, I want to go home, I'm going home. And they have watering bracelets on, but they'll cut those off, they'll get those out. They're very smart folks. And they want to go home. So the chances are they're on the way home if they can find a way. We contact cab companies outside as well, but we'll get into that part later. But we always send someone down from the unit who knows what the patient looks like, who knows what he's wearing, to see if we see him leaving the building.
Okay, so this, and I see that Hajra has her hand up, and I was going to say you haven't spoke on this yet, so I feel like I'll go to you, but I don't want to forget to bring up CCTV review because now that's come up a couple of times. So over to you. How are you folks doing things at Trillium?
So thank you for asking that question. One of the first things we do when, as all of these other organizations do, you do a check of the area, you try and find out if the patient is within the unit, break rooms, or any of the locations that they generally would be found at. But one thing which is very important that we think has helped us with expediting the process is actually doing a CCTV footage review where our security team will come in, support, and see when was the patient last seen where, and then try to track from, do we see the patient leaving the premises? And that usually helps reduce the time that is required to ultimately decide, is it a stage 2, is it a stage 3, has the patient left, and really helps the teams in finding out where the patient is. I did want to address one of the questions that popped up in the chat around, do you page the person overhead and state their name? And this is something, so our organization recently updated our Code Yellow policy last year, actually, not that recent. And we had a lot of discussion around, do we want to incorporate that overhead paging piece into this? And how do we do that? And there were concerns around the patient privacy piece. Do you want to state the full name? How are we doing? Because of those concerns, we actually did not incorporate that into our policy right now. And that is one of those safety, sort of patient safety and privacy issues you need to balance out as you're thinking about your internal organization. Every location, every hospital has a different need. So we did decide against doing those overhead pages where you're calling out to say, Miss Hajra Khan, if you're, at Tim Hortons, please return back to the unit. Because again, we don't know if the patient is comfortable with that. We want to make sure, we're protecting, their personal health information. So for that reason, we decided against that. And we did modify our overhead paging for stage 1, stage 2, stage 3 a little bit to definitely include information on, descriptors that we have, age, gender, identity, race, all sort of identifiers that can be helpful, what kind of clothes they're wearing. But one addition we did that typically organizations have that repeated 3 times, and it can be quite disruptive for the organization, especially during evenings when the rest of the patients in the organization are resting. So we do repeat it just 1 time, the detailed, and then our overhead page includes just that detail 1 time, and then another 2 or 3 times around. It's a stage 3 and what location the patient is missing from.
So this is also interesting because yes, I saw somebody put it in the chat, which I know folks that will see this recording later don't get to see, but that question about paging people to return. And we do also have that instruction. So what we've tried to advise at my organization is every patient, there should be some, or for others on this call, every resident, there should be some initial steps, regardless of who it is, to try and validate where they might be. And things can be done in tandem. So I think sometimes we get really caught up on this needs to happen, then this, then this. But we advise, you should be searching the unit, you should be reaching out to security, and we'll page the individual just their first name and last initial once to return to the unit. And sometimes the overhead pagings are for things other than a missing patient, where we're putting somebody's first name, last initial out there. But it just goes to show there's a little bit of variance even on this very initial start to get us rolling on Code Yellow. And that's why I wanted to talk about it. I didn't want to assume that everybody is doing things exactly the same. It sounds like a number of our panelists actually have a varying staged approach baked into their policies. But now I wanted to touch on, you brought up CCTV. Now we've heard that a couple of times. We've talked about outreaching to security. I mentioned to our panelists just before we started the recording, the challenge with this is how quickly are workers reaching out to security to review the cameras? Is that really an ingrained process? It sounds like it is for a few of you that the functionality is there. You have on-site security, you have good CCTV coverage. You're able to outreach as one of those initial steps to get the ball rolling, but it's not very useful if that person has been missing since, before shift change. Oftentimes people pick those times to wander away. So does anybody have any? I can see Greg smiling. It seems like that's usually the go-to time. And then it turns into, well, how long have they been missing? And if you can't give a time frame for that CCTV review, it's very cumbersome. So I think a few people on the panel wanted to comment about some of those pros and cons, how we're using it, maybe where some of those gaps are when it comes to including CCTV review. So who'd like to jump in to chat about that a little bit?
Maybe I can go again.
Go ahead, yeah.
Michelle, you're absolutely correct. As we were going through our policy refresh, we noted that there was issues with staff waiting until end of the shift to escalate to flag for security that a patient's been missing. Not always, but we saw some of those incidents happening, and we realized our policy wasn't clear on the timelines of what time should you be looking at before you escalate from a stage 1 to a stage 2 to a stage 3. And we put that into our policy. We baked that in as a requirement that as soon as you notice a patient is missing, within 30 minutes, you need to do a stage 1, all the activities, do the checklist of, all the locations within your unit, escalate to your team lead, notify security of this, that is a stage 1 right now. Within 30 minutes, if you're unable to locate, it becomes a stage 2. And then within 45 minutes of that, if we're still unable to locate, it may become a stage 3, or depending on the risk assessment, whatever the team feels is required. So we try to put those timelines in, and that really helps our security team as well to be able to say, okay, I'm looking at the last 30 minutes, or maybe I'm looking at the last 45 minutes, not at the last 12 hours, which can be quite cumbersome. We are starting to track what the adherence to that policy is as well, which is, again, recognizing the fast-paced environment our healthcare workers are in. It's still something we're working on, but we have put in those timelines to, again, help with our security team in our searches. So that's what we've done here at THP.
No, thank you for the insight. Again, especially because there's these different stages in your policy. I think it's helpful to kind of see where we're at across the board here. Laura, jump in on how are we getting the CCTV and security looped in with you folks?
So we start that process early. I would say it's like you mentioned, there's things that are happening in tandem. So I would say like our preliminary, which is pre-code, like we don't actually call the preliminary search, includes a call to security to start that process and a brief description of the patient. We, like you mentioned, we do have the staged approach. So our stage one is that local and now includes the start of the security search. And we can usually limit down to a time and a location to start that search on CCTV. In our transition to stage two, we do have, so the description of the missing person is provided to our switchboard. And we do have software that is inputted by switchboard and sent out to, and it goes to all network computers as a pop-up in front of everything that people are doing. So there's no overhead announcement with the person's description. We did run into the challenge that our security is not Joseph Brandt, like they're not our employees, they are contract employees. So we did have to do some workarounds to make sure that they got that description. But when we talked to them, they already had the description. So from that initial phone call, usually it's the charge nurse or the team leader or that kind of person that calls security to start that that kind of preliminary CCTV search while the rest of the team is doing their local search.
Yeah, I'll also say we have a contract security provider here as well. And that's another reason why we want to make sure that they're dialed in right away and they're getting that direct phone call about it. Scott, you've got your hand up next. How are things in Nova Scotia as far as, oh, wait.
Oh, I did. I put
There
it
we
down.
go. Yeah, jump in.
Yeah, so cameras, CCTVs, absolutely. We do, they're worked into our plans, including before Code Yellow was actually declared. When it works really well, and I'm sure others can attest. They have saved the day many times, one way or the other. I just jotted down some gaps, though. There's certainly quite a few gaps. One may be the early recognition. So at the staff level or the unit level, in that early stage, recognizing the fact that, oh yes, we do have security cameras, let's engage them, let's review them. So that can be missed sometimes. And we also, our security is also an external contractor, province-wide. And although they do a lot of work, it really varies on the capability of sort of the staff of the day. Sometimes it depends on the site and the experience of the staff, and even the technical ability to get in there and actually access and review the footage can be a struggle sometimes. Some people are excellent at it. They can do it really, really quickly, dial it right in, and other times not so much, and that can be a struggle. Another thing that we sometimes face, many of our rural sites or more remote sites, they have CCTV footage, but no security on site that's monitored remotely, so that there can be some logistical challenges with that piece as well.
That's a really great point, because so far it sounded like everybody's very comfortable and confident in their security teams, their camera coverage. But yes, there are a number of facilities that don't have 24-hour on-site security services provided. So you're going to have different strategies for those locations. Greg, you've got your hand up next.
Yeah, I just wanted to mention too about the when we find someone missing, there is that time frame, but it's also what type of patient it is that's missing. You know, what is it? One of our transients who's just decided he was going to go, that was it. Or if it's one of our ALC patients with a decreased abilities, then, you know, that the staff know that, and they know what that patient is. And if they know that it is one of them who's at high risk, like an ALC patient, then they'll go down right to the camera at that time, right to the security. And security for us is also a contract across the province, but it's they have the ability. There's always a shift supervisor there, and he has the ability to go through the cameras and to be able to look with that person. So I feel like it does depend on the patient when it is. We never give a description overhead. This floor staff had access to our emergency page. They can go in and put the description there of that. And then you can get an email or a text saying that if you sign up for it. With some folks like our EVS people who are all through the hospital, we have more EVS people at night than there are during the day, right? Because of the offices and everything they're cleaning. So they don't have access to a computer. So we would take a snapshot of that and send it out to their phones. So they have that description as well. So.
Okay, so before I get into talking about how we notify everybody, because we're getting into that too, and I think that's sort of the next question, right? As we've all been dancing around it a little bit, and don't worry, Grayson, I'm going to come to you about the security component here. Is we all have different procedures on how we're getting the notification out to the rest of the building occupants that somebody is missing. So before I address that question, just know that's coming next. Grayson, did you want to comment how you folks in Alberta tap into, your security services team for these kind of preliminary steps and CCTV review? Do you have thoughts on that?
Sure. So yeah, just as an overview, we do have kind of some disparity of resources and a mix of private and corporate services. We're very lucky in the urban acute centers to have some great protective services who are directly employed by Alberta Health Services, have direct access to all of the infrastructure. A little bit different between sites for sure. And sort of to your next point, the type of information they need is a little bit different than what they'd need for a physical search. Quite often, all they need is just like the time they wandered away from the unit, can rewind to that time point, see someone wandering away, tag them, and then just trace them throughout their system. So once the information gets there in a well-resourced site, it's a super valuable tool. And quite often they already have that person tracked before the notification ever comes out because they already knew about the risk and we're sort of already tracking that person. So really, really effective as long as the right information gets there.
Okay, so maybe before I start talking about how do we get the message out to the entire hospital, this is a key linchpin to everything, is that high risk status. So Grayson, I think like you were commenting, like just now, is what's being communicated is sort of based on the fact that this assessment has already been done. They're not searching for every single patient that's left their room. They're only getting tapped on the shoulder for specific patients that are more at risk or residents that would be more at risk. And I know early on you put in the chat some of that criteria on how you do the assessment. So maybe I'll keep the microphone in front of you for a moment to just explain who gets defined as high risk to require having the broader search.
Sure. Yeah, so this was the key change that was made to our Code Yellow procedures, was adding a risk assessment, partially to escalate to a higher degree of search faster, but also partially to kind of reduce the unneeded activations where it could be resolved, as everyone was talking about, by just doing a phone call or taking a quick look around. So yeah, that continuum of risk, low risk is patients who are outpatients, who can make their own decisions, who we know kind of leave AMA from time to time, have maybe even talked about leaving, and perhaps we just witnessed them leave. That's not really a reason to search the entire facility and expend resources there. That medium risk, and this is all based on perception, and that's an important training point as well, is we're not asking you to do like a really detailed risk assessment. This is, do you perceive this patient to be at risk? Act on that perception. We trust our staff to make those decisions, but here's some little criteria as guiding points. If they need help, if they don't have the capacity to make decisions, if they have a history of leaving and being at high risk, and if they have sort of environmental concerns, like they're not dressed for the weather or whatnot, that would definitely be a reason to search the facility, make sure they're safe. And then high risk, again, patient characteristics, like they're under the Mental Health Act, if they're a minor, if they definitely don't have capacity to make decisions, if they have a known risk of elopement or wandering. All of these things are really important, and that would escalate to an immediate full search as opposed to kind of creeping through the standard search procedures. And certainly that one would be overhead page activation of as many resources as we can to do that. To your point of kind of distribution, we're still in the forms. So we still have a form to fill out and then distribute that form with the patient information. I think there's lots of opportunity for integrating even existing technology. Like we have the Connect Care process where all that information already exists, and it might be easy to build that in. We're just not there yet.
Okay, and then Laura, so you had already addressed the fact that you have the screen takeover, which is notifying staff that there is this person, but how do you determine when somebody requires a facility-wide search?
Sure. We have, so, and this is something, I'm going to be really honest, this is the exact question that comes up at every debrief. So we have some really concrete ones. If the person is under the supervision of the police or Ministry of Corrections, automatic. Certified under the Mental Health Act, so on a Mental Health Act form, or the risk assessment includes consultation with the team. Like, is this person going to be formed in order for the police to bring them back? No, then they're an adult and they can leave. The patient factors, medical condition, right? It could be related to a general anesthetic. So it might be a short-term medical condition, cognitive impairment, risk of harm to self or others, history of attempted elopement, as was mentioned, and issues with custodial care or caregiver. So if there's questions about the person providing care for that person. And then again, environmental factors. My hospital is literally on Lake Ontario. So, cold, wind, rain, snow, any of those kind of things. And if they, didn't take their belongings and we know that they don't have the appropriate attire, those are the kind of things that move them from the low risk patient to the high risk patient. And especially if one of the things is early communication with the patient, if possible, or with the family, they're a really good source of, first of all, where to look and those kind of things, but information about the safety of the patient. And I think that they need to be included in that kind of risk assessment.
I think you make a really good point. Hindsight is always 2020. So when we've done a search for someone and after the fact it's being debriefed and it's, why did we search for this person? So we hear that come up sometimes. And so definitely you've touched on a variety of different elements that could be considered. And most of the time, I think staff want specific, it's just these types are the ones, and it's never quite that simple, is it? Scott, what is the triggering point for your teams to conduct one of these full building searches?
Thanks, Misha. So within Nova Scotia Health, this is how we define it. A code yellow may be necessary when there are reasonable grounds to believe that there is an imminent and significant danger to the health and safety of the patient or an identifiable group of other people. So that forms the foundation. It's similar to what other people have said. So examples of imminent and significant danger to the health or safety could include the patient lacks capacity, the medical condition of the patient, the age of the patient is an involuntary admission, and the final one is there is another identifiable concern of imminent and significant danger to the health or safety. So quite broad. But those are the main points that would cause us to pursue the code yellow piece.
I know for our organization, it's been a little bit challenging because you would like to think that this assessment is something that happens at, shift change. Somebody's coming on, this is who you're working with today. These are the people that are pre-identified as being high risk. But we know sometimes there are some additional variables there. But before I move to my own personal experiences here, does anybody else want to share any other criteria that I didn't hear from? Have I heard from everybody about, what needs to be considered to do that full building or facility search? Okay. What I was going to mention is something that comes up frequently is substance use. being a trigger. And I wanted to chat about this. It can be a little bit of a contentious subject, I think. I know our bioethicist here at our organization actually sits on a Code Yellow working group, and had really reminded, I think, the rest of us that our risk tolerance for someone with a history of substance use is much higher than their actual risk tolerance. And so sometimes searches have been called for someone and the report statement is, well, that person is going to go use. So we need to find them and bring them back. What are some of the examples that you struggle with as being more of maybe a moderate risk versus that this is a clear-cut high risk? Because for us, I feel like this is an element, but shouldn't be the be all and end all of why we would get the entire organization to look for them. Laura.
That specific example is our moderate risk. So particularly if the person has an IV. So the tolerance threshold for our frontline staff is the person has a history of substance misuse or like a recent history of substance misuse, not a remote one. And they are, for example, in hospital for sepsis related to a skin infection from an injection site. They think, well, that's the direct rationale to why they've been admitted, but they are adults and they're allowed to make adult decisions. And that is their regular risk of day-to-day living. So that is the conversation, again, that I have at most debriefs. That's primarily is about that walking through that risk assessment and, you know, and the documentation of that piece. I think that piece is huge. How do I document that? Because I'm a nurse by background as well. There is a lot of ownership on I let that person leave and something's going to happen to them. So.
Certainly, a lot of this comes from truly that sense of care. Like we said, like our risk tolerance for that person is, you know, so much higher. We don't want, sorry, I should say so much lower. I keep saying it in reverse. We don't want that risk on our conscience that they might go and use. But as you said, people do make very poor decisions about their health and safety regularly. And I think that's something that everybody on the call could agree with. When you work in healthcare, you see it every day. Hajra, over to you.
Another scenario that we've had to deal with is where, and as you said, Misha, you're so right, the risk tolerance for our teams is so much lower, where they feel such a huge accountability. So the case that I'll share is more about when you suspect some sex trafficking or human trafficking. There is no evidence of that whatsoever. The patient is not stating anything. And it's the team that has a feeling or a sense that we feel they're going to go out, they're going to be abused, they're not, you know, in a good place. How do we support that? And do we call a code? Do we call like a stage 3? How do we involve the police? And that escalation is what teams instinctively want to do. And as much as I want to support how the team feels about it, as a healthcare organization, we have our sort of, you know, regulations that govern how we function and what is our duty. And even from an ethics perspective, if it's a capable patient, and that's what we have, like if it's a voluntary capable patient, it's a low risk. You can't determine that. You can't be, you know, imposing your own understanding of their risk level on that patient. And that is really a struggle that we see with teams. And Laura is right, like even with substance abuse, like you really can't be imposing your own understanding of what the risk level is onto the patients, which can be tricky. And hence we've again tried to define some of those risk levels in our policy as well, between high, medium, and low. But if it's a patient who is capable and is able to take care of themselves independently, they can cope with the environment out there, it's a low risk. We're not going to be calling the police on that.
Excellent. Thank you for sharing. Do any of the other panelists have examples of sort of those ones that pop up so frequently in team discussions about the why or the why not? Greg, you've got your hand up.
Yeah, I just want to mention it. I love what I always find is with our transients It's always, we have to find them. It's like, people have a right to live at risk. That's their right. If they want to live at risk and they want to do what they do, then that's good. We'll provide the medical care for them, and we're there for that if they want it. But if they're of sound mind, we can't force them to come in and take the care, right? So they're going to leave on their own. Well, then he's an AMA, right? Left against medical advice. And, besides that, if they, if they're the ALC, I go back to ALC because that's our majority. That's the majority of the people we're looking for. And those are different, right? When it comes to that, but people who want to live at risk have that right. We all do. So
And I
that came
think
from an ethical guy too, right? So that's an ethical thing that a dilemma that we always been having, and that's his say on it is, that they have the right.
yeah, it doesn't make it easy for the rest of us to accept it, but it is actually a fact. Grayson?
Yeah, for Alberta Health Services, we've kind of covered it in a big statement saying history of living at risk, and up to the practitioner who knows the patient to decide what that means and if that necessitates a search. So that's in the medium risk category for us.
I know I try to take some examples that come from our incident reports, neutralize them to a certain extent, and share them for training when I'm out rounding on units and so on. So you try to give an extreme of this is a very clear-cut example of someone that desperately needs everybody in the building to look for them right away. And the other one, which is this was not a good use of resources. And this is the example of why staff members are fatigued in doing the searches and perhaps not being as dedicated to those searches because they don't feel some of these patients meet that criteria. I don't know how others are doing it, but it all goes back to the actual reporting. And I would say we struggle to get reports into our incident system consistently about missing patients because I think sometimes it's not viewed as being an actual emergency, even though it's an emergency code. Do folks, before we there's so many different lines that I could pull on here to say, let's talk about this, let's talk about this. But let's talk a little bit about your actual tracking of this. How do you get reports? What data do you collect on this, and how does that get shared? Grayson, your hand came up right away.
Sure. Yeah, I think this is an important one. Some of the data is kind of distributed against a lot of reporting processes. So at the urban acute centers, we have kind of a centralized switchboard who tracks every time they make an announcement about a code yellow, for example. That information is great for frequency of when the announcements were made. They don't always translate into this was actually a missing patient. Sometimes they return immediately or something like that. So reporting of patient impacts is a different system. So we have to consolidate those reports. And then if there was no patient impact, even if it was a search, it might not get reported there. So we have another system for reporting in kind of escalated site responses. So yes, I would say it is a gap in terms of reporting the impact. I think having lots of different reporting options is great, but we just need a way to consolidate them.
Okay, because I think a big part of this is how can you learn if we aren't tracking and sharing, and that criteria about the justification for doing a full search versus not, it might be that line. But if the team's able to articulate why they felt the person fit or didn't fit, that's the place that needs to be. It needs to be captured somewhere. And I think I know again from sort of our experience that sometimes the rationale for why they did or didn't call is just not being included in a way that's easy for us to go back and assess. I feel like I could talk about incident reporting all day. There's various gaps. Scott, over to you.
Thanks, Misha. Are we going to come to a communications question, or can I bundle that into the?
Oh, bundle away. Tell us about reporting. Tell us about your communications.
Okay, perfect. So in that phase one piece, before a code yellow was actually declared, it would just be simply verbally on the unit, passing amongst the staff. If they weren't located through that initial where are they piece, where most of the time they are, that's when it would shift up to the phase two, which would be the actual declaration of a code yellow. So there, we in Nova Scotia Health, we do have the overhead PA announcement. We do not include name, but we do include patient description, and it is announced 3 times. So there is that piece, and that would be communicated out broadly across the site via the PA system. We would also activate, so within Nova Scotia Health, we've recently, over the past year and a half, we developed a new process regarding incident management teams using Microsoft Teams, and specifically site incident management team channels for each site that we have. Really cool tool, a new one that we've developed, and it works really well. So when we have an emergency incident or planned event, depending on what it is, the site lead or the person in charge, or if it's after hours, which is a piece we haven't talked about yet, I guess, the difference between working day and after hours. After hours, we have a management on-call person who would be, that's that first point of contact for any major incident. Somebody would initiate via this Microsoft Teams site IMT channel a code yellow. And so that goes out to a pre-identified group, IMT members specific to the site, as well as certain zonal leadership, as well as provincial leadership. Initially, they would get an emerging incident. They would receive that. It would say code yellow, this site, this time, whatever details are put in there. And then also subsequent to that, situation reports would go out also via that MS Teams site IMT channel. One of the goals of that new process is to get away from emails with attachments, get away from group texts, phone calls, as much as we can, to centralize all of that in a single space. So within that site IMT channel is also where units or the search parties can update within this site IMT posts section. They can say this area has been cleared, this area has been cleared, cameras have been checked. So that chat, that discussion can happen internally within that site IMT MS Teams channel. And we do have attached to each phase, we do have various checklists that people are supposed to fill out and supposed to guide them through the process.
No, thank you for sharing, because I feel like there was a question that was put into the Q&A, and I don't want to miss Laura being able to talk about our previous note with reporting. But in the Q&A, somebody was asking about sort of when is your senior leadership notified, if at all? Because we've been talking about, okay, you're doing a facility search. This is how we're communicating to the team in the building. But is there certain notification? Does it depend on the situation? Is it standard for everyone? Are you notifying your leaders? So just while I have you on the screen, since you kind of talked about that a little bit, Scott, are there particular thresholds where it's okay, this person is missing, they were considered high risk? That's when it's getting communicated to sort of the zone leadership, or even, all the way to the top in your provincial network.
Sure. So with that list of criteria that I mentioned earlier, anything that would qualify as a code yellow by our definition should be submitted through this MS Teams, the site IMT MS Teams channel process. And attached to each site IMT, we have our local site leadership and incident management team members, but also attached to each site within the zone and expanded out across the province. So we have 4 zones. Each zone runs the system. We have a mirroring system, so it's around the same in each zone. Are the key leaders. So as far as the site leader, zonal leadership, and also provincially, we have a single duty officer on call. They do 1-week rotations. In each zone, we have a management on call person. Likewise, we have a provincial one. So they all receive this notification. Whether or not they have their notifications turned on or not depends if they're on call, but they all have access to this information. They don't all necessarily receive it in real time, but they have the ability to. And if the situation was really high risk and had the potential for, a significant response, either or an impact within the community or within the healthcare system. The idea is that those key leaders, they should maybe perhaps get a phone call to say, hey, this is happening at this site. Go and check out the site IMT channel, and they can keep up to speed within this channel. Our communications people are also included on those. I didn't mention that as well earlier. Nova Scotia Health will also put out social media posts. So on all of our social media platforms, if there's a significant code yellow and a significant missing person, that post will go out with the person's picture, full details on there if it's deemed necessary. Once the search has been called off, whether they've been found or not, that post is pulled down immediately. So it's not up there. It doesn't live there forever, but we do also post it on social media.
There's some things there that have prompted me where I don't want to forget to ask about how do we close it off? When do external partners get involved? So let's think about that shortly, but I'm going to come back to Laura. Do you have thoughts about reporting that you wanted to share, or additionally about when kind of your senior leadership may or may not get a notification?
Sure, and there's a difference between days and nights, right? Because if it's during the day, they're getting the notification. Our on-call, so we have 2 levels. We have a manager on call and an administrator on call. The manager on call is notified of every emergency code activation, and the administrator on call would be notified for us for a stage 3. So anytime we're looking outside the building, our internal search and sweep is done. I have the it's a blessing. It's a blessing. I also manage our patient safety incident reporting system. So all of our emergency codes also go into our patient safety emergency or incident reporting system. Although it is not a notification, because that's the last step for people to do. But what that gives us is I can reconcile with the overhead calls. What it gives us is a location to collect data and to store debriefs, search and sweep. So it's a central searchable location that we can store our data related to that activation. So I'm not sure that would be as functional if it wasn't the same person managing both things. So recognizing that sometimes that the reasons that things work is because of how they're managed or those kind of things. It may not work for everybody.
Yeah, some interesting feedback about how we're actually gathering this information in the first place. But over at Trillium, what is the reporting there as somebody that's, from the QRM lens?
So I want to talk a little bit about our on-call structure. As Laura said, days, nights, very different. We actually have a clinical operations manager on site during nights and weekends. We then have a director on call. We also have an exec on call. And with all those leaders, there's a daily touch point at 9:30 p.m. where any escalations, any sort of codes, active issues are shared, and it is more for an awareness. Our clinical operations managers are our leaders, boots on ground, and they are the best people, I would say the most fantastic group to manage these issues, and generally items don't come up, and it's more of a heads up, director on call, you have a code yellow and whatnot. If there is a high risk code yellow, which as we said is like, where as I think Scott mentioned, if we're potentially looking at a significant outcome or an adverse outcome, that may be shared with the exec on call, who may notify other senior leaders as needed, but not necessarily. It's more of a notification, just letting you know. Apart from that, whenever a team calls a stage 2 or stage 3, there is a standard email that goes out from our switchboard team on code alerts to say everybody, all leaders in the organization receive that email alert. And that is going to contain all the description of the patient, of where they were last seen, what to do. And that is sort of a notification for all leaders in the organization. We do use our incident reporting system sometimes, again, as it's voluntary. And as you said, Laura, you're not sure how it would be if it was not within your domain. that is used to report emergency codes, but I would say our key location or data source on codes, in particular, like code yellows, code whites, is our switchboard /C3 team, which track all the codes that came in and what the stage was and when they were called and what the patient was. So that's how we kind of track and notify here at THP.
So before I turn the mic over to Greg, I just want to acknowledge Grayson has had to step away. So he was sharing in the chat some of the additional challenges that they've encountered have included the decision making on when to release the bed, responsibilities for searching common areas, sort of how you're closing the loop on communication after the transfer of responsibility for research. So I don't want to ignore, we can definitely chat about some of these things because he'll still get to see the recording for any last minute pieces. But since this is a special panel, we are running a bit longer than we normally would. So for everybody that is able to stay longer than the hour, we're here for it. So Greg, over to you. Did you have some feedback to share about reporting or about leadership notification?
Yeah, at Horizon, we have like a duty officer as well, sort of the same. Sounds similar to Nova Scotia's. We have a facility duty officer who at night and during the day has in charge of they're the nurse supervisor sort of thing, and that they're in charge of the facility. We have an area duty officer who's on call, and that's like Scott had mentioned, 1 week at a time, and it changes. But it could be anybody. It's not really a clinical person. It could be a director of another program. And we have a network duty officer. So they're notified if it's depending on the risk to the patient. Some of the articles you showed earlier would be one of those risks outside in a snowstorm, and ALC with low mental capabilities, status sort of thing. And then when it comes to the note, a lot of people will put in the incident reports. We get information from our switchboard when they announce the overhead. We get all the announcements, and we get all the clears from them. So they have a board, they put it in a database, and we can take that information out. But with the incident reports, we have a pretty good uptake on that because of the ALC patients and people wanting to report that, you know what, we need to do something with the facility to ensure that if we're going to have these patients that we're built for it. So they figure we'll get locked doors, or we'll get codes on our doors or something for they don't leave. So we have a good uptake on with the incident reports. They go to RIS, and then RIS sends them out to us. And we review those, and we do the after action reviews on them to see what we can do. And there's been a lot of good suggestions come out of them. But you know what, we're still not at a place that we can keep these people, right? We don't have that capabilities. Fire codes are a different thing that we have to worry about when it comes to locking doors. It's, we got the fire regulations. So there's a lot of things that go into play with it all. But trying to making sure that we keep them in the facility. We have some of our facilities are in the city, and some of them were outside the city with woods. So if they get out the door, there's another challenge, right? If we're in a residential area, they could jump into a cab and go. If it's in one of the wooded areas, they can go into the woods, and then we lose them. But so we have partnerships outside with external stakeholders. Search and rescue is good for us, and some of those areas. They even have we're sort of looking at them. They have a GPS system now that they use for people in their homes, that we know if we have sort of a repeat offender in the facility that keeps going, that we could use one of those GPSs on him. So if he does get out of the facility and go into the woods, we'd have a better opportunity of tracking him where he was. So lots of things going on. It's I think it'll always be a challenge with the code yellows. I don't think there's an easy solution for it, but this is a good conversation, and thank you for inviting me.
Well, I feel like now you've broached into what I was going to ask as the next question, which is, how are we involving our other community partners? So at what point in time are we outreaching to police? Or depending on your geography, like you said, there's search and rescue teams, there might be some other potential community partners. In our organization, this is tied back to when our code can be cleared or not. There's elements that tie back to our notification to police for filing of a missing person. But we recognize there's some variables here depending on the person who's gone missing and some timelines to consider. So I saw Scott's hand come up right away. So at what point in Nova Scotia, Scott, are you folks tapping into, your different first responder or other community partners?
Sure, thanks, Misha. This one is really clear cut for us based on lessons learned, so it is crystal clear. So for us, the only reason law enforcement would be contacted is pursuant to the Personal Health Information Act, the Provincial Health Information Act. That's if one of the following conditions are met. There's 3 conditions. One of them has to be met, at least one. So the first one is there are reasonable grounds to believe that there is an imminent and significant danger to the health or safety of the patient or an identifiable group of people. Second one would be consent is obtained from the substitute decision maker where the patient lacks capacity. And the third one would be if the patient is involuntary. And then we have the authority pursuant to the Involuntary Psychiatric Treatment Act to make disclosure to police. So one of those 3 reasons have to be met in order for us to involve police. As far as search and rescue, that's police. We would never call in search and rescue. That would be the decision made by the police based on their investigation. So that's also easy for us. We do not reach out to search and rescue. That would be a police matter. As far as closing the loop, sort of backing up a little bit, the communication piece, whether a search is successful or not, we always want to close the loop on that. So we would essentially reverse the things that we did initially to announce it. So it would be an overhead announcement calling all clear. That Microsoft Teams channel piece that I mentioned, that would go out. We would say all clear. The social media post would follow up on the social media post, and that would be removed.
That's great. It's really nice when we can have elements in our policies that seem very clear cut, because I know when it comes to Code Yellow, there's a lot of elements that are nebulous, but our contacting of law enforcement partners should not be, hopefully. Laura, you've got your hand up. When do you guys get police connected?
So one of the things that I wanted to talk about before that police piece is the discussion with the most responsible physician, because our police team, so I mean, yes, we have a local police team, but I mean, Burlington is in between some pretty significant cities. So often our patients are in those cities. So it's a collaboration of police services. We really need to know, is the physician going to put a form on that patient to bring them back? Yes. Then we contact the police to do a retrieval of the patient. No, we contact the police to do a wellness check. So there's 2, we may still contact the police and say, and the police will still go to the person and say, they're worried about you at the hospital, they want you to come back, or the doctor says you have to come back, and then they bring them back. So that's a big piece for us. It's something we run into pretty frequently. And just because a person came in under the Mental Health Act does not mean that they would be brought back in under the Mental Health Act. And that's a really, that's a discussion with the clinical team. But as far as activating the police for the patient that we deem incapable, it's really about when we've exhausted everything in the hospital or we know they're not here. So we would contact the police immediately if we saw them leave the building. Or if we've done all of our internal search and sweeps and we've exhausted we've called them, we've called their family, we've exhausted everything else, then we would collaborate with our community partners. So those are the 2 circumstances. But the decision from the most responsible physician has been becoming more and more important on the direction that the police will take.
Really good point. So I think this, you just touched on it a little bit, and Scott, you were also sharing some information about how you folks close the loop, which is, since we started earlier on talking about, you know, facility-wide search or like a campus-wide search of some kind, when is this concluded? When are the actions by staff determined to be complete? Are there timelines? So for us, since, I mean, you know, Scott definitely seems like the tech savvy fellow who has fully embraced Teams, which is great to see. For our organization, we have an internal piece of software that we created, which is just to attest that a search has been completed for a geographical area. We tried to get away from, you know, folks having a paper map and you're collecting all of these things. If police arrive, we wanted to be able to tell them these are the areas that have been attested to being searched so far. These are the areas after hours that are open to the public, but we don't have staff in them. So these are areas we need to go search. So we created that internally. We still put a time limit that the entire search of our facility should be completed in like 10 to 15 minutes if people are dividing and conquering their specific response areas. We're going to clear any code yellow as of an hour, whether they've been found or not. We're no longer announcing for them. We're no longer expecting staff to be searching. Their search should have already been complete. And so it's trying to figure out what that conclusion looks like. And I'm going to take a wild guess and assume that we're all doing things a bit differently. So who'd like to talk about, you know, those higher risk patients? When do you determine it's all clear? What does that look like for you? Yeah, Scott.
I'll jump in there, Misha. If you listen really closely, you can hear my wife and my family laughing at the fact that you referred to me as the techie guy. I guarantee you that. So we do not have a clearly defined timeline. I love that idea of calling it one way or the other within an hour. So that'll be a takeaway for me and my team, is maybe we can drill down and adjust some of those processes. Right now, we do not have that piece. If they're found, obviously that's easy. That's declared all clear. Excuse me, one way or the other. If they're not located, as it sits right now, that would be a discussion that's had based on the assessment between essentially the clinical leadership and if police are involved in that police. So it's not clear cut for us. I wish it was more, and that's a really good takeaway for us and our team potentially. And we do not have something as advanced as tracking the time of the search built into Microsoft Teams or anything like that. That's also really interesting.
To clarify a little bit, that was a more recent update to our policy. And mostly it was to say we have to give a timeline that when it's announced to the organization, it's all clear. Doesn't mean that there aren't still steps that need to be taken, but we need to tell people when those steps need to be taken, when we move on to the next piece. And obviously, as you said, if they're found, fantastic. But we know that's, you know, only part of the frequency of our announcements. And before I jump over to Hajra about this, is also that determination of the person leaving the building has been a point of contention as well. It's been differently viewed here. If you could see them get in a cab or on the bus or in somebody's vehicle, you know they're gone. But if somebody has walked outside, have they walked in through another entrance? Are they still on the property? And so that was another piece that had to be considered to say, we've got to put some sort of time frame around this, keeping in mind that perhaps they're still on the grounds, but at least we can attest we've searched the building by this point in time. Hajra.
So as I mentioned earlier, we did put timelines around the time between calling different stages or escalating to different stages. So within 30 minutes, it's a stage 1. If you haven't been able to find the patient, you call a stage 2, and that's another 45 minutes. And if you haven't been able to, then it escalates to a stage 3. Or if it's a medium or low risk patient, as you said, if they've been found, excellent, back to your unit. If they haven't and they're low risk, medium risk, it is essentially a discharge from the hospital. And again, that's a conversation with the MRP. Either you form them and we then call the police and they're going to be bringing them in, or they're being discharged. I think for us, something that is a bit unique, and I haven't heard that conversation over here because maybe other organizations don't have that challenge. We have a significant capacity pressure. We, on an average day, have like 50 people waiting in the ED for a bed. That's a regular average day for us. It goes up to 100 when it's surge season. So you can well imagine that if there's a patient who's not in the hospital, is a capable patient, is well enough to cope on their own, and we have a bed empty waiting for that patient, staff and they actually don't feel comfortable with that, because we do want to pull in patients from ED who need that bed. So we've put in very clear timelines in our policy on how long are we going to hold a bed for a patient, if they're low risk, if they're medium risk. And if the physician is not going to be putting in a form, then we're going to be discharging. So we've kind of put in those timelines to say that if it's a low risk patient, for between 1 to 2 hours is the max we're going to wait for them. We're going to hold the bed for them, and then it's cleared and we have the next patient being pulled into that bed. If it's a medium risk, it's 2 to 4 hours. If it is a high risk patient, we do wait up until 24 hours for that patient to see if we can bring them back to the hospital and what supports we need from our police partners. So that is something we've kind of pulled into our policy, because that was a huge piece of contention for our staff to say, we have patients waiting in ED who need a bed. And they actually need this care, and you're holding a bed for somebody who just doesn't want to be here. And they're perfectly capable of making that decision of not being in the hospital. So that's something I incorporated in our policy.
So I'm sure Grayson is happy to hear that component, because that comes up frequently as a question here. I will say that we've tried to push that back as more of like a professional practice question, to say that our Code Yellow policy really has to be focused on that emergency consideration. And as an emergency preparedness subject matter expert, I don't want to be the one to have to advise on a particular timeline, but it has to be discussed. So Laura, I'm going to turn it over to you.
I'm going to put my nurse hat back on, because sometimes these people come back and they are in a different state than when they left the hospital. So I think that's one of the things that we have in our Code Yellow, is that there may need to be a different assessment of this patient if they did ingest substances, if they did get burned doing something. So we do also have included that it's not to clear a Code Yellow, but in the wrap-up stage, it includes a physician assessment or a consultation with our critical care response team. It has happened, and I'm sure it happens at Trillium too, where they're just too sick when they get found, and then they end up coming back in through emerge, and then that decision is they may need a critical care bed, so we're gonna move on to and put the next patient in the bed. So, I mean, we're probably only 30 minutes apart, so our stories are pretty similar. We're just a smaller community.
Just to add on to that, and absolutely, Misha, when we develop our policy, it's with our clinical folks, with our professional practice team, and everybody has put in their sort of feedback into this. And I agree with you, Laura. For our high-risk patients, where we, there may be, mental health considerations, substance abuse, we do hold the bed longer. It's not you're out of the hospital 2 hours, we're going to release your bed. We do hold it longer. And again, depending on what the clinical team suggests, it may be more than 24 hours. But anything beyond that, it would be back to ED. And then if it's a mental health patient, there will be different considerations on how to expedite the process and get them into the right sort of patient care space. And as you said, it depends on their needs. we do put them in as a priority.
So I've had to run to a headset. Hopefully everybody can hear me okay. I wanted to note also as well, Greg has had to depart, so regrets from Greg on the last few minutes here, but well, we still have a few of you on the panel. And I know we've now talked about a couple of these, kind of tense questions. There was one question that had been put in the Q&A that was asking about, is there ever a time where we end up applying this policy to visitors? Now, I will say our policy does not mention anything about visitors in it. However, it has been very infrequently used based on sort of a broader communication, not communication, broader discussion as a team about this particular person. So there's been a couple of visitors that they have been called for. Do you have any context from your own organizations that's in policy, or just perhaps an experience as far as applying this policy to folks that are not inpatients? Laura, jump in.
So there's not concrete policies on this, right? Our policy is written from a patient lens, although it does consider visitors and volunteers. But we have applied our Code Yellow principle relatively recently for a missing staff member who had a workplace violence incident, and then they couldn't find the patient. So we did activate, we called it a Code Yellow. Some of that was a bit of protection of that person, and some of it was to activate the search and sweep. And they were located in a stairwell in the parking garage. So it was, very specific. There wasn't cameras there, but it was just somebody that needed a few minutes away. It wasn't anything, super crazy, but people were concerned, and we have an existing process. So sometimes we try to fit the round peg in the square hole.
Yeah, and this is a part of why I think in mentioning that our own organization chose not to formally address it in policy, but recognize that the resource is there for those more of a fluke situation that it could be applied. Scott, what about in Nova Scotia?
Thanks, Misha. That's a great question. And Laura's example is really good. And I could see that being an area where it may be applied, but currently we do not have that addressed in our policy. It's designed around clients or patients or residents. So it's not identified anywhere in the actual response procedure. And to my knowledge, we haven't applied it to anybody other than a patient or a resident or client.
And Trillium, how are things done there?
So I'm gonna, as you said, I'm the director of risk as well in this organization, so I have like those dual hats. We don't formally address visitors in our policy, but if there were a situation where there was a vulnerable visitor that was at risk, we would be offering supports to the patient and other family members in sort of guiding them where to go, how to do things, but we wouldn't be doing our own individual searches. We may, again, as I said, depending on the risk level, if it is, for example, a young patient, I mean, we would be calling a code amber for that, but if there is a risk for an elderly visitor with a patient, we may do a search of our security CCTV footage just to support that conversation with the patient. Again, at the end of the day, whatever happens with the visitor is going to impact our patient directly as well. So we want to make sure that we're providing all the care. I do want to flag, I think there was a question addressed to me in the chat and I clicked, and for some reason I can't type it anymore, but I'd like to answer that.
I was going to ask it to you, so you were already on the ball.
The definitions for low, medium, high risk patient. What we have done is we've given a bit of a description, and I think Grayson addressed that as well earlier. If a high risk would be a patient certified under the Mental Health Act, any patient deemed at risk to themselves or others, any patient deemed cognitively impaired, as Laura said, it could be, your post-surgery. So that as well would be your, cognitively impaired, you're under anesthetic. And then any patient vulnerable to extreme weather conditions as well. We've specifically put it in our policy. Medium would be you're voluntary, you're capable, and you actually have a day pass, but you haven't returned in terms of your appointed time, and this the team feels you do need to continue with your care if they're not returned, and then anybody who's low would be capable, independent, can is able to cope independently, wasn't out on a day pass, and is really more of a just they were ready for discharge, for example, tomorrow, then we're not going to be categorizing them as a high risk. So those are our definitions.
Great. So we only have a couple minutes left in our extra special long session. And I think we've addressed most of the things that have sort of populated through the chat and also in the Q&A. I know there were a couple of things here that were touching on children. So just to clarify to folks on the call, because I know when we were talking about the emergency color codes and saying, well, we're applying code yellow as the topic of the day to this panel, that's in relation to adults. That being said, even the definition of who's being searched for is variable. In my own organization, it's anybody that's over the age of 15 counts as a code yellow. Anybody that's younger than that goes into a different emergency code, which is code amber. So just checking as maybe a last quick touch point here, does anybody have like an age distinction? Do you have it as 18? Do you have something else that separates children from your code yellow searches? Yeah, Scott.
Thanks. Just quickly, we do not. Currently, we do not, but we are currently developing that piece. A little bit of history. So Nova Scotia Health as an organization, provincial organization, has been around for about 9 years. Prior to that, it was 10 separate district health authorities who all had different details within their emergency color code response. So some may have identified that before or previously, but currently we do not. But we're working on it. Within Nova Scotia, we have the IWK Health Center in Halifax, which is specific to women and children. So that's our specialty hospital with regards to children and pediatrics. But of course, across the rest of the province, all of the rest of our facilities do take children as well. So currently we do not, but we will shortly. And I'm curious what others have to say about that.
Yeah, so also just to clarify before I jump to Laura to tell us how you're doing things there, there's also a bit of a differentiation here because when we're saying we don't formally acknowledge that we'll search for a missing adult who's not a patient, but I think most organizations will have steps for if there's a missing child, regardless of if they're a patient. So again, so that might have to be a topic for another day as to hash out what are we doing from the Code Amber front. But Laura, do you guys have criteria around the actual people that you're searching for in that way?
We very clearly define pediatrics in our organization is under 18, period. We may have those discussions. A lot of 17-year-olds are parents. So like there may be discussions, but the criteria is 18. And the main difference between the only real difference between amber and yellow is the immediate speed of things. It's an initial lockdown, and then it's essentially the same processes without the 15, 30, 45 minutes. So everything is now. The call to police is now, and the lockdown is now. So the search and sweep process is the same. It's just the lockdown process that happens immediately with an amber.
Okay, so any last thoughts? There's only a couple minutes left here before we wrap up the panel. Obviously, I could talk about the subject all day. Part of the reason why we wanted to pull this panel together is there's been lots of peer conversation because there really are variables, again, between a single facility versus a network, whether you have acute, whether you have long-term care, whether you have ALC, like there's so many things to consider here. So hopefully for folks who attended, our panelists were able to address some of those burning questions that maybe help you feel not alone in navigating this policy. But I want to thank all of our panelists, including the couple that had to step off just a little bit early. Really appreciated being able to have varying perspectives on the panel today from across the country. And again, from different site types, from network to acute specific. So again, thank you so much. I'm going to turn it over to Francesco for our final word.
Thank you, Misha. And yeah, thank you to all of the panelists. I just want to quickly echo my thanks as well. So thank you to everyone who took the time to join us. Thank you um, to those who had to sign off early, to Grayson and Greg. If they see this recording, thank you very much. And thank you, of course, to Misha for all of your help putting this together and organizing the session and the series. And thank you to everyone in the audience for joining us and hanging out for an extra long session today. So we appreciate that a lot. And then just as a quick reminder, this is being recorded, so it'll be up on our YouTube channel as always, and it'll be up on the series webpage as well. And we are currently working on finalizing the details for our December 3rd session, so please stay tuned for that. Again, on our social media, or on the event page or on the CFAL York homepage, you'll see all the details about that once it's announced. So yeah, thank you so much. And registration is always open and free, so please share that with anyone who might be interested and who isn't registered yet. And with that, thank you all so much. I hope everyone has a great day or a night wherever you may be. And yeah, thank you again, and we'll see you in a month.